First session. We have 10 minutes, I think, for questions. I've been looking forward to some questions. So, if there's questions, please come to the mics. In the meantime, Prism, there are laws in the United States with suspected non-accidental trauma that is required to report. There are now no states where it is illegal to ask a question about firearm ownership. Those are critical movements in the essence of firearm violence and pediatric violence. What are the laws and what are the practices? What are your recommendations on either reporting after you've asked that question, or what is our responsibility?
Yeah, thank you for the question. And I have to say, I think that's one of the biggest barriers and people are fearful of for good reason. And so knowing your local resources, but also your local legislation is extremely important. So in Canada, it actually varies slightly between our provinces. One of the most important things to know is if there are children in the home. And so if you do have a conversation about violence in the home and there are children under the age of 18 in most of our provinces, you do have an obligation to report that. And that feels as though it's this huge barrier. So why would I ask? I don't want to deal with that. I don't have time. I'm way behind in my clinic. But that's where I think that second point about really getting to know your social services that are available. So this is where you bring in a social worker. And I've had this experience now several times, and being really honest with your patient about, I have to let you know, I really appreciate and acknowledge this, but the best way that I can help you is actually to bring in my social worker, because we have to take care of the kids in your home, and that's the best thing that we have to do. We do have to report this. And not once has that actually been received poorly. I think there's quite a sense of relief, to be quite honest. And so that's not the job of the orthopedic surgeon. I can't say that enough. This is our goal, I think, is to open up the conversation, normalize some of this language, and then get to know your local resources so they can help you out.
Thank you. Yeah, that's critical. So, Tim, the notion of trauma call is something that the OTA had addressed, I would say 15 years ago, as far as a responsibility, but a responsibility also of the systems to cover and compensate for that time. So I want to ask about someone who takes call in your area. What is your relationship, or what does the hospital relationship in terms of backup for a non-trauma person taking call?
Well, we've got 6 hospitals in our area. One is a level 1 trauma center, and the other ones are more community hospitals. And so the beauty for a joint surgeon, for example, taking call at one of the community hospitals, more than likely knows the orthopedic traumatologist that's on call at the trauma center. So if a bad intra-articular plateau with a compartment syndrome get taken over to the other hospital, they can transfer into the trauma center. And so that kind of one of my messages was that you may not have the luxury of having that close relationship that we do in a small town environment, but to absolutely know what your transfer opportunities are, I think that's really critical.
Yeah, and thanks. We did a national trauma action plan with ACS, College of Surgeons, about 3 years ago, and looking at coverage of areas throughout the country. And the rural areas are not always covered by a trauma system. If you're in an area where you're covering call and there is a trauma system, though, it's really important to understand for the Baltimore area, we have shock, which everyone knows, and then we're the other trauma system within that, but we're still part of that trauma system. So access to that trauma system is one call, and they regulate to where a patient is coming, if it's a transfer, if it's a referral. In our own system, we have 3 trauma centers, and so there's always a trauma surgeon on, whether it's a backup or a primary. Every night there is a trauma surgeon. So if that system is available, then it makes it safe and comfortable for sports or other professions, spine, to cover that call, knowing that there's backup. And so I think that Dr. Schmidt is coming to the. Are you going to ask about the team game?
Well, sort of.
Okay.
But it gets to this whole thing about trauma. So, there's call, but there's also sort of informal communication. We've completely lost that. So in Minneapolis, a lot of the residents we train stay in the community. And we'll at the trauma center, we're like I think most of them, we're really stressed right now by lack of beds. OR access at night has become a problem sometimes, in the last year especially. And we'll get a call to our transfer center that they'll want to transfer, for example, a geriatric pelvic fracture. And a lot of those patients don't even need surgery, but the outside institution, the ER calls the orthopod says, well, it's a pelvis, I don't do pelvises, transfer it to Hennepin. And these patients come and take up a bed, and then we don't have nursing home access. So sometimes those non-op pelvises could be in the hospital at our place for a week, and really needing nothing but therapy. And where's the communication? So I was on call a month ago and got one of these calls and found out who was on call. One of our residents called him, and he didn't even intend to transfer the patient. He fully intended to take care of it, but it was on a hospitalist service or something. And but then he told me about another patient that he really probably did need surgery, and we hadn't heard about that one. But just an example, there's so much that could happen to facilitate care. For example, a plateau with a compartment syndrome. A lot of times, if the trauma center can't take it, the referring doc could and would be comfortable even putting the X-Fix on in the fasciotomy. They just don't want to have to do the definitive care. And so we've lost that communication among our colleagues.
No, I agree. That was kind of the message I tried to deliver yesterday. I mean, I get so many calls, there's a upper extremity surgeon, taking call, and a tibia fracture comes in. So, well, I'm a hand surgeon. No, you're not. You're an orthopedic surgeon, okay? You can put a splint on, you can transfer the patient, probably doesn't need to come tomorrow. And then vice versa, the joint surgeon will say, gee, I don't do hand. I mean, everybody can get out of providing care. So my message is just, you're an orthopedic surgeon, be a doctor, and take care of the patient. Transfer the ones that you think really need it.
So let me tie that in. Thank you, Andy and Tim as well for that. Let me tie that into global orthopedics. As a specialist, do you have to be a trauma surgeon to be doing global orthopedics? And how do you approach overseas orthopedics within specialties?
Yeah, well, I mean, the fact of the matter is that most of the people who are doing these volunteer activities are not trauma surgeons. And it gets back to the basics that you're just, the same basics that apply that Tim was talking about, that you operate within the sphere of what you can do, work within the environment that you're presented with so that you're not just this lone wolf that's going and doing things and creating havoc and then leaving. And frequently, a lot of these missions are now including an educational component to this, so that you're going and you're working with the local teams, you're a collaborator with them, you're educating them, you're being educated on what they have, and you're working together. And that's really the most effective model. In certain circumstances like disaster management, that sort of infrastructure relationship may fall apart. But largely, most of the volunteer activities are not those, and they just involve people working together, communicating, and then being reasonable about what they are doing or not doing. There are two studies that I didn't put in just because of time that we've done that looked at, as we are trying to educate our residents and going over, because we have a resident education program that we've had for almost 2 decades. And when we question the volunteers coming to the States, they want more hands-on work, but they like the education piece. And so that part works for them because for the most part now, it's not legally feasible for people to come in and be able to operate. It's too restrictive in terms of our state and hospital regulations. Then the even more surprising part of that was in the residents when they went over there, the surgeons and the teaching programs that they went to were not so much saying, oh, we really needed them to operate. They were more saying, we really need them to come and help us teach and give us some tips about how we can set up our infrastructure and develop collaborations. And if you ask the residents are there to operate. So we just have to keep these things in perspective.
Yeah, thanks. That's great. It's 10:15. Are we done?
You can just a couple more.
Dr. Chang, could I ask just to talk about, you touched on it with metal artifact reduction. I think it's one of the most significant advances in our ability to look past the screws and plates and detect. How do you envision that moving forward? How do you want us to to request that? What are the limits and the benefits of a metal artifact reduction?
So certainly metal artifact limits evaluation on both CT and MRI. And so I think it's helpful if we are aware that the patient has hardware, if they haven't had imaging at our facility so we can't see that they have hardware. If we're just told that, then oftentimes when we protocol, we'll specify that it should go on the scanner that has the metal artifact reduction package already so that we can scan. That's, for example, for CT, so that we can scan utilizing the metal artifact reduction algorithm, and so that can really help us and help you. And then for MRI, kind of similarly, as long as we're aware that there is a metal in the patient, then we can protocol when we get the request for that study, that will put it on a lower strength magnet, and then also ask them to use metal artifact reduction principles. So primarily the main thing in the communication between orthopedics and radiology is just letting us know what is present in the patient and what limitations might be present so that we can address that when we protocol our studies.
Great, thanks.
Jim, can I make a comment? Yeah. Dr. Harvey and I were talking, and how many people in this room in your programs have a hip fracture protocol, hip fracture program? How many of you who are taking call fixing hips work in an institution that doesn't have a hip fracture protocol? So about half. So I think one of the messages we would have is that's probably one of the greatest things that you could take back from this meeting today is to go to your institution and begin participating in developing of a hip fracture protocol. You'll save lives, you'll save money, patients will get better care, and I think it's something that's it's going to get bigger and better, and it's going to be problematic as the year goes by. We have what we call an opioid-free hip fracture protocol, so it's really been effective. We looked at a bunch of patients who had complications. All of them got narcotics, and so as soon as we took narcotics out, our metrics improved. So develop a program, try to stay away from opioids, and you'll do your community and your hospital a huge service.
Thanks for that. That's great. This is a great panel. Thank you all for speaking, and thank you all for being here. So.